Hello, I'm Cecilia Binda and I'm a gastroenterologist at Morgagni Pierantoni Hospital of Forlì and Maurizio Buffalini Hospital of Cesena in Italy. On behalf of my co-authors, I would like to thank Gastrointestinal Endoscopy for accepting our studies entitled EUS-guided gallbladder drainage using a lumen-apposing metal stent as a rescue treatment for malignant distal biliary obstruction, a large multicenter experience. I also would like to thank for inviting me to participate in GI's Autos Interview series. So, first of all, what does EUS gallbladder drainage as rescue means? This is an option of drainage that has been proposed for the relief of jaundice in case of distal malignant biliary obstruction after ERCP failure and after failure of other EUS-guided biliary drainage such as hepaticogastrostomy or choledochoduodenostomy. The failure may be due to several reasons like altered anatomy, duodenal invasion, or small diameter of the common bile duct, less than 15 millimeters, or of the left hepatic duct, less than 5 millimeters. This technique grounds on the possibility of the bile to flow from the intrahepatic ducts and the common bile duct in the gallbladder through the cystic duct. So, to perform this procedure, the patency of the cystic duct is a crucial point and need to be verified before moving to this technique. This technique should therefore be distinguished by EUS gallbladder drainage in the setting of acute cholecystitis and should also be distinguished by the prophylactic gallbladder drainage that has been proposed in case of cystic duct involvement by the tumor or by the cystic duct occlusion by the placement of a fully covered self-expandable metal stent during ERCP. But why we decided to perform this study? As known, the rate of ERCP failure in case of distal malignant biliary obstruction varied widely within studies, being near to 0 up to 15-20% in some series. While standing to a recent study, the rate of failure for EUS-guided biliary drainage is around 7%. So it is easy to understand how real candidates to this procedure are usually very few, and although EUS gallbladder drainage could be considered an easier technique comparing to other EUS-guided biliary drainages, there are still few data on this procedure. Indeed, evidences come from at least case reports or small series of patients, and both were used self-expandable metal stents and lumen-apposing metal stents. That's why, with the IUS group, we decided to collect data regarding this technique throughout Italy. The IUS group is a group created in 2019 with the aim to support educational programs to improve and optimize interventional EUS procedures, including those with LAMS, in clinical practice, and above all, to promote studies on interventional endoscopy. The aim of this study was to evaluate the outcomes of patients who underwent EUS-guided gallbladder drainage with lumen-apposing metal stent as a rescue treatment, including 14 Italian centers from June 2015 and June 2020. To date, this represents the largest study on this technique using LAMS and shows how this technique is safe and effective for this setting of patients when other techniques fail. The drainage was technically feasible and successful in all the patients, while the technical success was achieving up to 81% of our cohort. Regardless the route of drainage, transgastric or transduodenal, the decrease in bilirubin levels within 15 days was very satisfying up to 66% from the baseline and was comparable to those shown with EUS-guided choledochoduodenostomy. Not least, the rate of adverse events was acceptable, around 10%, being complication mainly mild or moderate in severity, and no fatal or severe adverse events were present in our cohort. So, what should come next to this study? First of all, we need to better assess long-term outcome of this procedure because it's still unknown on how long the cystic duct remained patent during the oncological history of these patients. For sure, we need a direct comparison of this technique with the standard EUS-guided drainages like hepaticogastrostomy and choledochoduodenostomy, and it's still a need for a better evaluation if there's a preferable route of drainage, so if transgastric or transduodenal, in this setting of patients. Not least, it should be very interesting to evaluate if this procedure could be an option of drainage even for those patients that could be surgical candidates in the future. So, I'm concluding, thanking once again GI for the acceptance of our paper, and I hope you enjoy the reading. Thank you.